Good morning, everyone. I'm Mr. Chow. I'm from the ENT department of Hospital Sultanah Nura Ismail Batupat. And today I'm going to talk about common ear diseases. So before I begin, I'd like to thank the organizers from Hospital Mua ENT department for inviting me to give this talk. There are many ear diseases that we can talk about, but I'll run through quickly on what the common ones that we actually see in our emergency, outpatient, and clinic settings. Before we move on, let's look at the anatomy. Anatomy of ear. Ear is divided into outer ear, middle ear, inner ear. Outer ear has the auricle, the EAC, external auditory canal. Then from the tympanic membrane onwards, there's the middle ear, which the ossicles are located, and the inner ear, which has the semicircular canals and the cochlea. Let's talk about external ear. External ear, we start off with auricle. This is the anatomy of the auricle. We divide the causes, the common ear diseases of the auricle into acquired and congenital. Now in acquired, we look at trauma, inflammatory. So let's move on to the topic itself. Let's start off with hematoma. So what's hematoma? It's basically a collection of the blood between the auricular cartilage and the perichondrium. Now it occurs commonly on the anterior surface where the skin is actually adherent to the underlying perichondrium. Clinical presentation, there's a history of trauma, like for example, motor vehicle accidents, sports related, things like rugby, mixed martial arts, boxing. You know. And usually it may be painless, but an inflammation is minimal. But if you leave it untreated, you would see there is like a classic cauliflower ear that forms. So if you look at people like Mike Tyson or Evander Holyfield, I mean, before Mike Tyson bit off his ear, you can actually see the cauliflower pattern there. It's very classical. Rarely, a supervening infection can lead to perichondritis and cartilage necrosis. Now, what's our management for these patients? You aspirate it with a tick-borne needle. Now, if it's inadequate, you do an incision. So once you remove the hematoma, there's going to be a potential space there. So you need to actually compress it to prevent recollection. So what can you do about that? You can use pressure bandages or splints. You can use a true and true mattress or quilting suture, with the material as you compress it. What we can use things like cotton wool bolsters, dental rolls, buttons, silicone rubber splints. But we need to give antibiotic prophylaxis. And usually after 7 to 10 days, the aspiration is ineffective. Now let's look at this picture here. You can see that's a hematoma on the left side. The incision is as drawn there. Of course, you don't have to make such a big incision, depending on how big the hematoma is. And of course, you can see that the dental roll is actually tied down with a mattress suture on the right side. Next up, avulsion and laceration. So, like any avulsion or laceration in your body, you need to clean the wound thoroughly. You need to deprive any necrotic material. Now, the main thing about the ear is that there's a cartilage there. So your skin needs to be well opposed to cover that cartilage because you want to prevent cartilage necrosis. In adults, you can use non-absorbable sutures because you can easily remove them later. In children, do consider absorbable because it's already difficult enough for you to actually suture it. Imagine trying to take out the sutures in a clinic in a child. So absorbable sutures would be recommended. This is the picture of a laceration. You can see, so the blood's actually covering the cartilage. But once you clean it up nicely, you need to actually oppose the skin properly so that there's no cartilage seen. Next up, keloid. So keloids may form like in any part of the body, secondary to trauma, to piercing of the ears. Of course, because piercing of the ears are usually at the lobule and helix, so that's where its common site is. So how do we manage this? We can give repeated intralesional injection of steroids. So patients need to come frequently to the clinic for the steroid injections. If it doesn't work or if it's too large, you may consider surgical excision. But you may want to tell the patient that this can always occur despite surgical excision. So this is a keloid formation over the left ear. Let's move on to inflammatory process, perichondritis. So define them as infection or inflammation involving the perichondrium or external ear. How do they present? The classical signs of inflammation, dull pain, increasing severity. And it's usually at the cartilaginous portion, so the lobule is usually spared. And of course, patient has a background history of trauma or any forms of trauma to the external ear for that matter. Differential diagnosis, a relapsing perichondritis. So perichondritis itself is localized, relapsing is systemic, and may involve cartilage structures in multiple sites, ocular conditions, as well as vasculitis. So this is a perichondritis. If you look above there, you can see that there's possible abscess formation, subperichondrial abscess. So that's all that we talk about subperichondritis. Let's look at it. If the perichondritis is untreated, the abscess will form, and this may lead to avascular necrosis of the underlying cartilage, and again deformity, the cauliflower ear in the pinna, or even worse. So management for perichondritis, IV antibiotics, broad spectrum, focusing more on the Pseudomonas aeruginosa organisms. If there is a subperichondrial abscess, you may need to drain. You will need to drain, actually, not may. You will need to drain. So prevention is careful placement of ear piercings. Surgery in and around the ear should avoid traumatic cartilage. Tight head bandages should be avoided. So, like for example, in mastectomy, post-operatively, do not bandage too tightly around the auricle itself. So now we have been done with acquired, let's move on to congenital. Microtia, preauricular sinus. Microtia. What's microtia? Microtia is basically the ear being smaller than it usually is. That's a layman term. So we like to classify it using the marks grading system. So left side, you see the normal ear. Oh, then grade 1. It looks a bit smaller, but everything, you can see the helix, you can see the tragus, just a bit smaller. Grade 2, even smaller, but once again, you can distinguish the parts. Grade 3, severe malformation. Cannot identify the parts. If you look at it closely, it looks like a peanut. That's why some mention it as peanut ear. Grade 4, anosia. No complete absence of the auricle. Now, it may be associated with congenital canal atresia or canal stenosis. There are environmental like drugs, like for example thalidomide, or genetic factors, or craniofacial anomalies, syndromes. The child will have conductive hearing loss. How do we manage this? Multidisciplinary team approach. Hearing rehabilitation and cosmesis is the focus. Now for cosmesis, 3 options. You either have no intervention, no surgical intervention. You use autologous cartilage for ear reconstruction or bone-anchored auricular prosthesis. Hearing rehab is using a bone conduction hearing aid. Either the hearing is held down by the soft band or use a bone-anchored hearing aid in which you have a titanium screw to hold down the hearing aid. Now, factors that we need to consider for the surgery. Timing is crucial. Now, you want to ensure that there is enough requisite amount of cartilage. So we try to delay until the patient is roughly about 8 to 10 years old. And of course, the child's ability to cooperate with the demands of surgery. It's not a single surgery. It may require multiple surgeries. Imaging and temporal bone needs for further evaluation of the hearing structures like the inner ear, as well as surgical planning. Next up, preauricular sinus. It's a blind-ended sinus as a result of incomplete fusion of your cartilaginous tubercles. It's associated with branchial otorenal syndrome. Branchial meaning the branchial arch, so branchial arch anomalies. Auto, the ear, so ear anomalies. Renal, kidney. The clinical presentation, apparent at birth and often bilateral. Now, sometimes, most of the time, it's actually asymptomatic, but they may have sebaceous discharge from the punctum, and they may present with recurrent episodic infections, which may actually progress to abscess formation. So that's an image of the left ear, and you can see the preauricular sinus pretty clearly. There's no discharge, there's no abscess formation. Management-wise, you look for any other associated external abnormalities. You do an ultrasound kidney for the renal disease because you need to rule out the syndrome that I mentioned previously. If the sinus is free from infection, leave it alone. You don't have to do anything. If there is repeated infections, you need to excise it. If there's an abscess, drain it first, excise it later. So we make an elliptical incision, around the punctum. We track it. So we track it, we're instilling methylene blue so that we can see where it is. So you need to remove the tract itself. And also you need to remove a portion of the cartilage that is adhered to the tract. Because if you don't remove the cartilage, it's going to recur. Now we're done with the auricle. Let's move on to external auditory canal. So external auditory canal divided into cartilaginous and bony portions. So what are the common diseases? Impacted wax and cerumen, the most common thing. So the wax is composed of sebaceous secretion from the sebaceous gland, ceruminous glands, hair, desquamated epithelial debris, keratin, and dirt. It's acidic, so it has bacteriostatic properties. It's a protective function. It lubricates the ear canal, and it entraps any foreign materials. So, what are the clinical features? You tend, because it's impacted, so your hearing is definitely reduced. You get a sense that the ear is blocked. If it's pushing against the tympanic membrane, it's going to cause you some tinnitus and giddiness. And of course, patient has a history of usage of cotton bud and ear digging. So this is how wax looks like. It's a bit brownish. This is more in the Asian community. Brownish, wet, a bit moist. There's another type. It's a bit flaky, yellowish. Now, that's more in Westerners, but in certain Asian communities, you can also see that. So these are the two types of wax that are usually present. What do you do for the patient? So when you're able to visualize the wax, as well as the external auditory canal, you do your oral toileting via suctioning. If the wax is hard and impacted, please do not attempt to suction it. You're going to cause more pain and trauma. Soften the wax first using solvents, and then you can clean it up nicely. You can syringe the ear, but I wouldn't advise it because you can't see the tympanic membrane. Who knows? There may actually be a perforation there. So when you syringe it, instead of removing the wax, you may not only remove the wax, but you may actually instill water into the middle ear. So that's pretty dangerous. Next up, foreign bodies. Okay, very common in children. You have animate, inanimate. Animate, live insects. Inanimate, organic. Organic things like green peas, unorganic beads. Corrosive would be like things like button batteries. So sometimes the child may be asymptomatic or may present with otalgia or even ear discharge due to infection of the because the foreign body has been left in there for quite a while. And the foreign body usually is impacted at the isthmus, which is the nervous part of the external auditory canal. So this is an image of a foreign body, quite clearly seen. You don't even need an otoscope to see this. So let's look at particular foreign bodies that we need to watch out for. Button batteries. A button battery, because of the alkaline that seeps out, it causes tissue necrosis, which can actually erode structures in the ear as well as cause granuloma formation. So a button battery is considered like an ENT emergency. You need to assess, you need to attend to the patient, and you need to remove the battery as quickly as possible to prevent any tissue necrosis. In insects, you try not to remove it alive. Because now let's look at the situation. Imagine there's a robber. Are you going to run towards the robber or you're going to run away from it? You're going to run away from it. That's right. So the insect knows that you are guarding the external auditory canal. So naturally, there's only two pathways. Through the external auditory canal wall, which is hard, or through the tympanic membrane. So you're going to cause more trauma and edema and even pain. So kill the insect first. Okay, you can instill things like sodium bicarbonate, instill even antibiotic drops, and drown the insect before you remove it. Now, if at first attempt you can't remove the foreign body, please refer to an ENT clinic. In adults, usually we can remove with ease because the patients are cooperative. In children, it may require general anesthesia. Next up, otitis externa. So it's actually acute chronic inflammatory reaction of the skin, okay, in the EAC. You have local factors, warm, humid climates, when you swim, when you remove all your earwax, because you actually increase the pH in the, and therefore the bacteriostatic properties are removed. Trauma, which includes foreign bodies. Systemic things like eczema and dermatitis, patients that are immunocompromised, like diabetes mellitus, and anyone on immunosuppressions. You can divide them into diffuse and localized. So let's start off with acute diffuse otitis externa, known also as swimmer's ear, because swimming actually caused it most often. diffuse infection in the EAC. Pseudomonas aeruginosa, Staph aureus, one of the most common causes. See, and also because of heat and humidity and trauma, which may lead to asthma here. Clinical features: pain. Pain is the principal symptom. Now, the ear canal is swollen, red, itchy. You see debris inside, deep into the canal. Tympanic membrane usually intact but inflamed, and there may occasionally be surrounding cellulitis. Now, the otitis externa may also be secondary to middle ear discharge itself. This is an image. You can see all the debris inside. It looks a bit narrow, but you probably need a toilet before you can identify whether the EAC is narrow. So what do you do for the patient? Oral toileting. That is the most important thing. Then you may want to insert a ear wig if the external auditory canal is edematous or narrowed. Okay. Antibiotic steroid combination drops may also be instilled. Okay. And you may give all antibiotics if there's no response to initial topical therapy. Now, if there's any underlying factor, you need to remove and treat it properly. If not, it will recur, and then chronic CT may develop. And of course, if there's recurrent episodes, naturally it's going to lead to stenosis of the external auditory canal. Next up, localized otitis externa, or known as furunculosis. Now, Staph aureus is the most common because it involves the hair follicles in the EAC itself. So multiple follicles causing it, furunculosis. So, extremely painful swelling is usually at the cutting portion of the EAC. Okay, pinna is painful to touch, may have coexisting diffuse otitis externa. You may get post-auricular swelling because of the retroauricular lymph nodes behind there. So you can see this is the image. This looks like a boggy swelling. Okay, a furunculosis on the superior part of the external auditory canal. So you need to do oral toileting. Of course, if there's an abscess, you need to drain it. And you will need to insert a wig because naturally it's going to be edematous, inflamed, and a narrowed external auditory canal. You instill antibiotic steroid ear drops or glycerin ectomol solutions. You need to give oral anti-staphylococcal antibiotics like cloxacillin. Adequate analgesia needs to be given for the patient. So let's move on to automycosis. Automycosis is like the fungal infection of a diffuse otitis externa. Otitis externa being bacterial, fungal, automycosis. So you have Aspergillus candida. Itchiness is the main symptom. Okay, you can see debris, especially like it may resemble a cotton wool in candida, or as we call it, like a wet newspaper. Or then you may see obvious black spores in Aspergillus infections. Now, what happens is automycosis may occur due to instillation of chronic usage of antibiotic eardrops, or you may suspect it happened because of failure to treatment of significant period between 3 to 4 weeks of antibiotic eardrops. You can see the fungus spore quite clearly, so this is definitely automycosis. Treatment-wise, oral toileting, insertion of a ear wig, antifungal drops, at least 4 weeks because the spores are highly resistant. There is no role for systemic antifungal. Let's move on to malignant otitis externa or necrotizing otitis externa. Now, it's not a cancer, but basically it's aggressive and life-threatening because it can involve the periosteum quite quickly and the bones of the skull base. Etiology-wise, patients with diabetes mellitus, that is the most common thing. Any immunocompromised patients. And as Pseudomonas aeruginosa is the most common species involved, Staph aureus aspergillus very rare. Clinical features: severe autarkia. You get granulations on the floor of the canal. You may lead to lower cranial nerve palsies, things like petrositis, Gradenigo syndrome, where you get retroorbital pain, sixth nerve involvement, and ear discharge. Okay, so diagnosis is history and clinical findings. You do a CT scan or MRI of skull base and brain. Isotope with the bone scan. Okay, isotope bone scan may be done. You may need to do biopsy of any granulation tissue to rule out malignancies. You need to send for microbiological specimens to identify whether Pseudomonas, laboratory full blood count, ESR because you need to monitor the disease progression. Of course, you need to check for the blood sugar levels as well as patient's renal function because you're giving antibiotics. So you can see there's some granulation tissue there, and there's some debris in the ear. This is the diagnosis criteria, called Cohen's criteria. This is how we diagnose and differentiate it from a severe acute otitis externa. Now, you give the patient anti-pseudomonal systemic antibiotics, 6 to 12 weeks, ciprofloxacin, ceftazidime. Okay, these are one of the antibiotics that are anti-pseudomonal. Admission for assessment and for control of diabetes. You need to regularly toilet the ear. Instill antibiotic steroid drops. Surgery is not required unless there's no improvement and you need to debride the area, as well as sending any specimens for microbiological or histological studies. Okay, so we're done with external ear. Let's go on to middle ear. So middle ear, this is your tympanic membrane. This is the left ear. Very nice looking tympanic membrane. It's normal. Let's start with acute otitis media. So acute means less than 3 weeks. It's acute inflammation by a pathogenic organism in the middle ear cleft. Very common in children, 16 to 24 months. Now, etiology virus, the most common, influenza A, B, RSV, rhinovirus. Bacteria, you get the same things that you get in the pharynx, Streptococcus pneumonia, Haemophilus influenza, Moraxella catarrhalis. Now, you have the pathophysiology. So first is hyperemic erythematous inflamed. Subsequently, there's exudates. Now, the exudates will lead to superimposed infection, which will lead to suppuration. And of course, the next step will either be, if you treat it, then of course it's going to resolve. Otherwise, it may perforate and there may be mucopurulent discharge. Risk factors, you can see young age, family history, bottle feeding, daycare centers, poor socioeconomic factors, any smokers, and any anatomical changes, cleft palate, craniofacial anomalies that would cause the fluid to build up in the middle ear, and as well as adenoid hypertrophy, infection of tonsils. So this is almost similar to this otitis media with effusion, but effusion is not infection. This is infection. Clinical features. So initially, as I said, it may precede a upper respiratory tract infection. So there's buildup of pressure in the ear, fullness sensation, and the tympanic membrane will be inflamed or dull. Then subsequently, there will be severe otalgia because it starts bulging, pressing, pyrexia. Child will be very irritable. Then you see a bulging, tense erythematous tympanic membrane. And if you don't do anything, it's going to perforate. The only good thing about it perforating is that it improves the otalgia, but then there's going to be mucopurulent otorrhea and a big hole in your tympanic membrane. You can see this red, bulging, angry-looking tympanic membrane in this image here. So what is management-wise? You consider admission for the patient with severe otitis media. Okay, analgesia, antipyretics. So antibiotics can be like amoxicillin. That's your first line, or Augmentin. You give for roughly about 10 days. You need to consider IV if the symptoms don't resolve within 72 hours, or it's a second episode within a month. Surgical management, you may need to proceed with a myringotomy and gourmet, as well as adenoidectomy, because you want to prevent any complications. For example, if the patient has frictional palsy, okay, you need to relieve the pressure there. Or acute mastocytitis, it may be done in conjunction with a cortical mastectomy. Now, if there's failure of symptom resolution after 2 courses of antibiotics, it may be considered severe intractable otalgia fever, 24 to 48 hours, recurrent acute otitis media, immunocompromised state, toxic patients, newborns, or anyone with any craniofacial disorder of cleft palate, which would actually exacerbate the situation. Now, circular, as I mentioned, perforations. Now, if it causes purulent discharge or bacterial infection, ossicles may be eroded. Atelectasis, cholesteatoma may follow. Speech impairment or even learning disabilities because of the conductive hearing loss. Let's move on to otitis media with effusion. So that's collection of fluid in the middle ear. It's not an infection, okay? There's just fluid in the middle ear. Also known as glue ear. There's a bimodal distribution, peak years between 2 years old and 5 years old. So risk factors include similar to acute otitis media. Now, clinical features, there will be poor speech development because of the conductive hearing loss, okay? Behavior changes. And in the otoscopy, you will see some yellowish, grayish, dull appearance with or without visible fluid level. Look at this. This is yellowish, actually. And it's actually, there's no fluid level because the whole thing is actually filled with fluid. Now, you will do a pure tone autogram, which will actually show a mild conductive hearing loss. A tympanometry will usually show a flat type B. Now, management-wise, you can watchfully wait. If there's no infection, the natural history dictates that in 3 months' time, 50% of children, it will resolve spontaneously. Now, autoinflation techniques like Valsalva or even an autovent may be helpful. Okay, short course of antibiotics, not antibiotics, but intranasal steroids of less than 6 weeks. If there is associated allergic rhinitis or adenoid hypertrophy, you may consider mygotomy and Gourmet insertion with or without adenoidectomy if there's significant hearing loss of more than 20 decibels for at least 3 months. Patients with craniofacial abnormalities, neurodevelopmental delay, significant speech and language delay, or recurrent acute otitis media with otitis media and effusion. So this is a grommet, okay? So if you look at this in the clinic setting, do not be worried. That's not a foreign body. That's actually a grommet inside the tympanic membrane. So let's move on to chronic otitis media. Chronic otitis media, the latest classification we can see as mentioned here. So we divide them into mucus and mucosa and squamous. Mucosa being the pars tensa region, pars flaccida is squamous. So whether it's inactive or active. Inactive meaning that there's no discharge, active meaning there's a discharge, and squamous is a cholesteatoma. So let's start with the first one. Inactive mucosal chronic otitis media. Now, it presents at the pars tensa region, either as a dry perforation. So like this, you can see that it's almost a subtotal perforation. You can see the middle ear mucosa, or a retraction of the pars tensa itself with no perforation. When we talk about pars tensa retraction, we can divide them into SADE classification. Stage 1, you can see that there is mild retraction. Okay, there's no middle ear fluid. Stage 2, the pars tensa is severely retracted. The tympanic membrane is in contact with the long process of incus. Okay. Stage 3, it's actually plastered to the promontory, but it's not adhered. Okay. And stage 4 is considered as adhesive otitis media. Basically, you can see the entire structures of all the middle ears because the tympanic membrane is literally adhered and draping the promontory and long process of the incus. Now, in active mucosal chronic otitis media, so this also known as chronic suppurative otitis media without cholesteatoma. So there's presence of chronic otorrhea with a tympanic membrane perforation. So clinical features, you will see a tympanic membrane perforation. You see recurrent chronic mucosal otorrhea. It may be foul smelling also. Hearing loss may be present. There may be signs of infection previously, like oral polyps and granulation tissue. Okay, so what you need to do is you need to do regular ear toileting. If it's chronic, you may need to do a ear swab for microbiological studies because you may need to treat it accordingly. Topical antibiotic steroid preparations with or without all antibiotics. If the ear has been dry, you may consider a laryngoplasty or surgical repair of the tympanic membrane. Now, next up, let's look at the pars flaccida now. We have what we call inactive squamous chronic otitis media, and we classify them based on the TOS classification. Now, if we look at the small little dimple just above the malleus, so that's TOS 1, okay, the small dimple there. TOS 2, you can see that the retraction is actually adhered to the neck of the malleus, so it's wrapping it, draping it around it. So the dimple is it's a larger dimple, you will call it. Stage 3, you can actually see the fundus, okay, and there is actually erosion of the attic area and the scutum, but you can see the end of the fundus there, okay. And in stage 4, you cannot see the end of the fundus. There's keratin debris stuck to it, okay. So let's move on. Next thing is if there is active squamous chronic otitis media or cholesteatoma. So the definition of cholesteatoma is a 3D epidermal structure exhibiting independent growth, replacing middle ear mucosa, resorbing underlying bone, and tending to recur after removal. Now, clinical features are actually similar to CSOM or chronic suppurative otitis media. You get scanty, foul-smelling discharge that may be bloodstained. Patient may present with autalgia, headache if there's intracranial extension, vertigo if the semicircular canals are involved, hearing loss, conductive because of the ossicular erosion, sensory neuro because the toxins may actually migrate into the wrong window, because patient may present with facial nerve palsy. Now, examination, you see keratin debris, foul-smelling discharge. There may be oral polyps, granulation tissues may also be seen in the EAC. Now, there will be retraction pockets or even a marginal perforation of the tympanic membrane. What you need to do is you need to do examination under microscope. You need to tolerate it properly to identify the extent of disease. You need to see the condition of the tympanic membrane and whether there's any involvement of the ossicular chain. All this is important for us to stage the disease. Now, investigation-wise, you do a swab, auditory assessment to give you a baseline hearing for this affected ear, as well as the non-affected ear, and a high-resolution CT temporal bone, which would allow us to demonstrate the underlying anatomical variant, surgical landmarks, and diagnose the extent along with the nature of the pathological changes. So you can see that this is pretty retracted. You can see keratin debris that's actually stuck above at the retraction pocket area, as well as the erosion of the scutum. So management-wise, we may treat the patient conservatively, but we wouldn't recommend it. Usually we keep that for patients who are medically unfit for surgery, or if that's the only hearing ear, because one of the risks of surgeries is the loss of hearing for the patient. So we can give topical ear drops, regular ear toileting, regular follow-up. Surgery, we can divide them into cranial wall up and cranial wall down surgery, or as you call it, mastodectomy. So cranial wall up can be a cortical mastodectomy, athecotomy. Okay, cranial wall down will be more radical. So you have your modified radical mastodectomy as well as your radical mastodectomy. The canal wall down just means that we bring down the posterior canal wall, okay, so that we connect the external auditory canal to the mastoid cavity to allow us to identify the disease and clean the mastoid bowl more easily. So that's all for my talk today. These are my references, and this is where I got my images from. And with that, thank you very much.